Hi, everyone. On today's CME series on lysosomal disorders, we're going to be discussing the advances in gene therapy for lysosomal diseases. So these are my presentation. We will describe the limitations and unmet needs of the current therapeutic landscape for lysosomal storage disorders, review the principles of gene transfer therapies for lysosomal disorders, describe the best clinical practices to monitor the safety profile of the gene therapy, and describe the best practices for gene therapies in general. So anyone that has seen and treated a patient with a lysosomal disorder should be aware how the treatment and the treatment response get challenging for a given patient. The reason is it is not one pathology contributes to the whole clinical picture, but multiple pathophysiologies actually end up what we see as the clinical spectrum. So from the disease-causing mutation, we have a disease-associated protein that can go either way, either gain of function and also loss of function at the same time. So at the end, that's all the disorders actually converge into the inflammatory response with immune dysregulation and inflammation. So the current therapeutic landscape for the LSDs include obviously the enzyme replacement therapy that has a past of more than 25 years that started with Gaucher disease. In general, the exogenous recombinant enzymes have mannose 6-phosphate tags that are recognized by the mannose receptors and taken into the first to the tissue and then shuttled or the traffic to the cell. That they overcome the catabolic pathway block and affect the clearance of the stored substrate. But as we all know that the enzyme replacement therapies are or large protein, large biologics, and they do not cross the blood-brain barrier. This actually takes us to the small molecules. Small molecules, obviously, they're chemicals. They can disperse in the multiple tissues and in the bloodstream. With a given time, they actually have a steady state, so that can overcome the peaks and valleys that we see in an enzyme replacement therapy. They, in principle, reduce the production of a substrate by inhibiting the upstream pathways. Some small molecules, they may cross the blood-brain barrier because they're small enough and they use the appropriate channels and receptors. These small molecules, actually, in general, we're going to be talking about substrate reduction, but also they include chaperone therapy and some other small molecules such as cyclodextrin, cysteamine, arimoclomol, so on and so forth. So in general, when we look at the current landscape of LSD treatment, obviously these are the disorders we're going to be reviewing: MPSs, Pompe disease, Gaucher, Fabry, and Krabbe. So we have the FDA-approved enzyme replacement therapies that actually exist for all these 4 disorders that we discussed. And in human trials, there is this CNS administration of ERT or brain-penetrant ERTs that's been approved in Japan for MPS II. For Pompe disease, there's the hypermannosilated ERT that got recently approved in US last year, in August to be exact. So obviously we are also still conducting trials using enzyme replacement therapy with a chaperone, and also the human trials are underway for gene therapies that include for Pompe disease, upcoming therapies for Gaucher disease, and obviously Fabry disease gene therapies have been happening for a while. And in clinical stages, all these disorders, they also have preclinical development of gene therapy, and also hematopoietic stem cells have been used as off-label for Krabbe disease and other disorders. So in principle, the enzyme replacement therapy, they mainly treat the systemic manifestations of LSD. There is one intrathecal form of ERT has been approved for Batten disease, that actually the intraventricular administration that bypasses the blood-brain barrier. But obviously the limitations of enzyme replacement therapy include, but not limited to, so these are large proteins that are not nascent to the host. And so basically we see hypersensitivity reactions that may range to a simple allergic reaction to full-blown anaphylaxis. Obviously, the ERT is very short-lived in the periphery, require repeat dosing, and also for neuronopathic forms, you need to administer to the brain, which is very invasive. And efficacy is affected by limited tissue penetration that include lack or very limited tissue penetration to the lungs, to the bones, to the cartilage, so on and so forth. And also that all of them have very short half-lives, and then obviously they are costly therapies. So when we talk about substrate reduction therapy as a small molecule, these are in general what we're talking about glucosylceramide synthase inhibitors or glucosylceramide synthase pathway inhibitors. There are approved therapies as substrate reduction therapy for Gaucher disease, but also there are trials that are underway for treatment of Fabry disease, Tay-Sachs and GM1 gangliosidosis. So for Fabry disease, there is also a chaperone therapy recently approved that is included in the small molecule therapies. So let's switch to gene therapy. And from this point on, I would like to briefly talk about the mechanisms of gene transfer therapies. We're going to be actually focusing on the AAV-based gene therapy or gene transfer therapies. I'm going to briefly mention about the ex vivo gene therapy, but what I want to focus from this point on is mainly the immune response to the gene transfer therapies and also the mitigation of this response to prevent the complications. The reason is both the efficacy of a gene therapy actually depends on the immune response, but also any clinician that will be following patients that have been administered gene therapy should be aware some of the complications related to gene therapy and need to learn the timelines for these complications, potential complications, and also how to mitigate that. So when we talk about gene therapy today, we are basically talking about gene transfer therapies. In principle, there is the in vivo where the gene product is transferred into cells while in the patient, and the other technology is ex vivo, where the cells are taken from the patient, a certain cell type, the genes are modified in the cell, and then the cells are then transferred back to the patient. So, and when we look at obviously the genes are in a very simple saying, they're transferred using the capsid of a virus that has the potential to infect the multiple tissues, but obviously they are rendered not harmful. So when we look at the vectors in general, this adenovirus-based vectors are the primary means of introducing genes into the humans right now. And when we're looking at these trials, AAV type viruses actually are the primary means of being used as vectors. This is a 2019 reference, and there were more than 244 trials. And when I look at different kind of resources, the current trials range between 159 and with more than 50 of having a preliminary outcome measure. So very briefly on hematopoietic stem cell gene therapy or ex vivo gene therapy is this is actually have been approved for monogenic blood disorders such as SCID and beta thalassemia. So gene transfer occurs into autologous hematopoietic stem cell progenitors to treat the monogenic disorder. So these are CD34 plus positive T cells and gene-corrected HSPCs, and their progeny can be also excluded as gene cell vehicles to deliver the molecules into the circulation and tissues, and also they also have glial cell penetration, and gene editing technologies such as CRISPR-Cas could be exploited in this kind of gene therapy. Let's switch the gears and actually dedicate the rest of the talk on AAV-based gene transfer therapies. Why AAV is so much actually broadly used right now. So obviously, if anybody who could remember the timelines of gene therapy when the retroviruses were used originally, actually that's the catastrophic, the first trial for a urea cycle halted the gene therapy because of the fatality associated with it. And for some time, we did not have any meaningful result for a gene therapy protocol. However, from the beginning of 2010s, the animal studies coming about the safety of AAVs. AAV is the short for adeno-associated viruses. So basically, these are faulty viruses, and they lack main pathogenicity, but they are very efficient in transduction into non-dividing cell. And also the AAV genome can persist for a long time after a single administration in the animal studies. So there are multiple AAV strains with different tissue affinity, and in the approved treatments, AAV2 and 8 have been used for ocular therapies. And also AAV vectors are versatile and can be designed to target various tissues by the tissue affinity of the particular serotype. Among these, AAV2 and AAV9 are the muscle and CNS targeting, and AAV9 can cross the blood-brain barrier. AAV also can be designer made, so they can be custom made by mixing and matching vector elements to target specific tissue types. These are also called designer AAVs. However, all these properties that makes the AAV very amenable for a gene transfer therapy can also its rate limiting factor. So AAV, they have limited cargo capacity, and also there is a widespread pre-existing immunity to the AAV. So it is a small genome, it's 4.7 kV with an inverted terminal or ITR sequences and 2 genes in cap and rep. And to basically, in a very simplistic terms, again, to manufacture AAV vectors, this cap and rep are removed, and then cap, rep, and helper proteins are expressed from other DNA sequences. So basically, you express the genome of interest. So basically, that is the virus can transduce, but cannot infect in the terms of basic viral pathology. So from this point on, actually, we want to talk about the immune mechanisms and vector attributes. The reason is we discussed, or we said that there is a pre-existing quite widespread immunity against AAV vectors. So from the previous studies, we know that the immune-mediated toxicities have occurred in several trials that had been attributed to empty capsids or hypermethylated CpG motifs. And similarly, AAV vectors with different design elements aka the designer AAVs, may lead to differences in product attributes and may play a role in triggering the immune system. And the immune reactions that is from immediate hypersensitivity to complement activation and antibody formation have occurred. So pre-existing humoral immunity to the vector is about 30 to 60%. In our experience, we run few gene therapy trials currently, is about 50, 57%. The seroprevalence of the neutralizing antibodies against the wild type AAV varies also geographically, and also for some disorders, I think is more prevalent than the others. So the titers of IgG type antibodies correlate with the neutralizing antibody titers, and also there is a broad cross-reactivity among the AAV species. So if a trial is run by a certain type of AAV, and also the patient has antibodies against that AAV, there is a likelihood the patient will have antibodies to other AAV species too. So antibodies can be actually mediators of toxicity. So there is the complement activation. So currently there are no trials that actually utilizes or that is done in patients with even with low titer antibodies. So there is also pre-existing T-cell immunity that is less studied than the antibodies. So exposure of PBMCs to the AAV capsid epitopes induced CD8 positive T-cells with effector memory, secreting TNF-alpha, granzyme, and CD107A. And also there is transient activation TK cells in seronegative patients. So if a patient doesn't have already existing immunity, what happens when we infuse the gene product? There is an induction of humoral response to the vector. So that is towards the capsid, towards the genome, and towards the transgene products. So all these three different elements can induce the activation of NF-kappa beta and the interferon regulatory factor with the release of type 1 interferons, and that in turn induces the T cell or adaptive immunity. So you start with the humoral response, but you end up with an universal T cell or adaptive immunity response. So basically there's a cytotoxic CD8 plus CD8 positive T cells drive the clearance of AAV transduced cells. So basically when we start losing the AAV, then it is the humoral response is switching to the T cell response. And we said also there is the transgene product, the response that can be towards the transgene. That actually interplays between the host factors, which is the pre-existing immunity, that is the disease state, which is the inflammatory state, as we discussed or said that all the LSDs are inflammatory disorders, the genetic background also among the host factors, and also the vector factors such as the serotype, target tissue, vector dose, purity, so on and so forth, and also which organ that we are targeting. So the combination of the AAV capsid, the vector delivery route, and whether it's local, such as to the eye, or you give systemically, when you give systemic administration, obviously there is more immunogenicity. So these are some of the examples of the immune responses. Obviously, there is, let's just look at some of the safety of previous AAV gene transfer therapies. So the gene therapy for SMA have been actually approved. What they have in the trials, there are patients with elevated liver enzymes, but there are reports recently from Eastern European countries that they are actually 2 infants have died of acute liver failure after the gene transfer therapy for SMA. So when we look at the other, the safety issues or the SAEs, they include reduced platelets and RBCs, complement activation, acute kidney injury. So in the recent DMD trials, actually one of the Duchenne muscular dystrophy trial had been halted past winter because of actually all these, the reduced platelets, RBCs they are also called TMA or thrombotic microangiopathy that can range from AHAS or atypical hemolytic uremic syndrome to one of the elements, either reduced platelets or you can see actually reticulocytosis because of the destruction of the red blood cells, also kidney involvement with the capillaries with proteinuria, so on and so forth. So when we look at the safety of the AAV gene transfer therapy and the timelines, they include the pre-existing immunity. So this actually precludes the administration of gene therapy. So if the patient doesn't have the pre-existing immunity and then the gene therapy product or the is administered to the patient. In the immediate, obviously, there may be acute allergic or the immune hypersensitivity reactions. But when the innate immunity gets activated, acute toxicities that can start between 24 to 48 hours, up to 4 days, and can last up to 15 days. So what we're looking here is the activation of the complement system and the impact of the complement system activation to the end organs that include kidney, lungs, heart, so on and so forth. So from 4 to 8 weeks, the adaptive immunity from the innate immunity takes over, as we discussed. The cytotoxic T cell responses, basically with the pro-inflammatory state, actually that decreases the efficacy or the transduction of the gene therapy product that can lead to high titer neutralizing antibody formation and then the transgene immune responses. So the potential solutions to the innate immunity activation, so basically inhibition of the complement and IgG absorption, and for the long term, for the transduction efficacy, we're talking about immune suppression, then as general strategy that is going to suppress both the innate and T cell mediated immunity. So from this point on, I would like to invite Dr. Sonata Jodele, who is an research professor at Cincinnati Medical Center. Dr. Jodele's research had been focusing on the immune activation, the complement activation, and that leads to thrombotic microangiopathy. She's an internationally recognized expert in transplant-associated TMA, and her groundbreaking research is rapidly transforming the way that how we perform the gene therapy. She received her medical degree from Vilnius University School of Medicine in Lithuania and got her board certification in pediatrics at SUNY Health Sciences Center at Brooklyn in New York and in pediatric oncology at Keck School of Medicine. She is, as I said, currently working as a research professor at Cincinnati Children's Hospital. So I'm going to give the word to Dr. Jodele to talk about TMA associated with gene therapies and the mitigation strategies. Thank you.
Thank you very much for this nice introduction, and thank you for inviting me to your meeting, to CME course, to share our experiences so we can learn from each other's disciplines. and I will discuss thrombotic microangiopathies as one of potential complications in gene therapies. Here are my disclosures. So thrombotic microangiopathy is now quite well recognized potential complication of gene therapies, and especially adenovirus-associated gene therapies. These TMS can present with variable severity and been observed in multiple studies already, like for patients with spinal muscle atrophy, Duchenne's muscular dystrophy, Danon disease, including a case of very fatal TMA in a young child who had likely underlying complement defects. TMAs as a complication has been addressed by FDA and European agencies, so we're striving to learn more so we can prevent those events from happening. To our understanding currently in gene therapies, TMA can occur about within 1 week of initiation of therapy, with usually the earliest markers being thrombocytopenia, elevated LDH, and terminal complement activation that could be measured by elevated soluble C5b9 in the blood. TMA usually aborts within a couple weeks, but it poses high risk for organ injury due to severe complement activation. And severe complement activation has been implicated as potential culprit of TMA-associated organ injury in gene therapies. Those organ injuries present in a kind of similar pattern to what we've seen to other TMAs, and I will share some experiences with you today. Gene therapies are promising therapeutic options, and we want to keep our patients safe. So we want to identify those preventable complications. And with TMA, we could do that with rigorous screening for TMA, and also we have complement blocking agents in selected cases if needed. So ultimately, we would like to develop screening and prophylactic strategies so we don't see this problem. And definitely we can learn from each other. For those who are less familiar, TMA, any type of TMA belongs to a big group of disorders under complement-mediated disease syndromes, familiar HUS, TTP, transplant TMA, HELP and eclampsia, all those disorders fall under same umbrella. So they usually present with microangiopathic hemolytic anemia, but more importantly, they all have final common pathway of endothelial injury that present with certain organ injury that could be very severe. Here is just to remember very complex complement cascade that we all studied in college, medical school. And we know that there's classical, lectin, and alternative pathways that they all lead to terminal complement activation. And this schema shows a little bit of the drugs that we're learning about right now, like mostly C5 blockers, MASP2 inhibitors, C3 blockers. So why I'm bringing this picture up, complement system overall it's a good thing because it's part of our innate immune defense. But it's almost like a fire. If it's nicely content and doing its job in fire pit or fireplace, it's good. But if it gets out and it's overwhelming, it usually has very severe complications. So we want to know how to identify and how to control those surges of complement activation. Here's a big list I will not go over, but as you see, complement inhibition is a big attention of research right now, and multiple disorders have complement system involved. And the idea is to identify when you need to intervene, when you don't, and when it's beneficial. So we're learning, like I said, from each other. Some novel thoughts on the complement activation and inhibition is coming from different disciplines. For example, we're seeing severe complement activation in hypoxemic brain death. And this is really significant for organ donation outside of other clinical situations where you see significant hypoxemic brain injury. We see it in the vascular emergencies like MI and stroke, when you have a complement surge and you have a complement deposits in the cardiac tissue. So those are kind of new fields that we're learning more. And those are very like acute emergent fields where we don't have too much time to think. We need to know what to do with these patients. We also are seeing a significant complement activation in traumatic brain injury and also demyelinating disorders. It's been kind of clearly showed that complement can be deposited on injured neurons. And again, this is another target we could think about in certain disorders or certain emergencies. We are learning a lot about complement from our current pandemic with SARS-CoV-2 infection, as it's been shown that the complement system is really heavily involved, especially lectin, alternative pathways, is heavily involved in patients with COVID infection and who present with thrombotic microangiopathies. And as you see here in a figure on the right, you see very significant complement deposits in the vasculature and endothelium in multiple tissues of COVID-affected patients. So now today I'll concentrate a little bit on the field that I am doing research and I'm most familiar, and we're learning a lot about thrombotic microangiopathies. So it's a transplant-associated thrombotic microangiopathy. And namely, I'm talking about a stem cell transplantation, not solid organ transplantation. So in our patient population, TMA, it could be a very significant, severe and life-threatening complication. And very often, outside of presenting this hemolytic microangiopathic anemia, and really presents as multi-organ injury, this kind of classic presentation. Although we have such a complex patient population that we have to work with multiple diagnoses, but we could share some of the learning points from our experience. So TMA incidence is pretty high in our transplant population. In allogeneic stem cell transplant, where a donor is other person, usually up to 30% incidence of TMA occurs in children, and about 20% in adults, the current reports. In auto transplant, where donor is itself, it's less known, but we know certain diagnoses like neuroblastoma and pediatrics have very high incidence of TMA. Now, TMA quite often goes with high-risk features, which would be complement activation and organ injury. And about half of any TMA presentations could be quite severe. And if you have a severe presentation with organ injury, mortality is very high. It could be over 90% mortality. So it's a very challenging disease to deal with very high mortality. So today, gold standard for TMA is a tissue diagnosis, usually kidney. But as you see here on the top panel, kidney biopsy is quite classic. In any TMA would be looking quite similar, where you have a thickened capillary walls, fragmented red cells stuck in the vascular lumens, endothelial injury on electron microscopy. But in a systemic illness, you can see that in any tissue, like a lung, bowel, brain. The challenge is that biopsies are quite difficult to get in the patients who are very acutely sick with thrombocytopenia, other organ injury, or if TMA is occurring so acutely that your patient is getting so sick and you don't have that opportunity. So we so far rely on a clinical diagnosis using laboratory tests, and also we're learning to recognize clinical organ injury patterns. So put kind of all phenomena together. And as you know, vessels are everywhere, so you can have any organ injury. So from a laboratory diagnostics, TMA usually in transplant population is defined by more than 4 of those 7 listed criteria. That includes elevated LDH above normal, schistocytes on peripheral smear, de novo thrombocytopenia or anemia or requirement of transfusions, arterial hypertension that is excessive for age and therapy that is given, proteinuria, and complement activation measured by soluble C5b9. And proteinuria complement activation can be shown multiple times to be a high-risk disease features. So classic organ injury, you need to think among differential diagnoses. TMA is a vascular endothelial injury, so it will be a primary endothelial injury, usually presenting as oxygen exchange in the lungs, let's say, or as bleeding in some other organs. So in intestines could be ischemic colitis with pain and bleeding. In lung TMA, it could be hypoxemia, pulmonary hypertension. In CNS, against bleeding, seizures, press. It could be even in the skin as vasculitis, and technically can be in any organ. As I mentioned, histologic tissue evaluation would be great, but it's hard to get, so it's not mandatory. If you have it available, it's good. And complement stains could be also done in any tissue. But I wanted to mention that for TMAs who evolve very fast and have fast progression and you sample tissues right away, you might not see complement deposits because it takes time to deposit complement. So if someone presented acutely, you got tissue, you stain for complement, it might be negative. That does not exclude TMA because it has other histological features that you get diagnosed. Now I would like to think about parallel between transplant TMA and HUS. And you know HUS, atypical hemolytic uremic syndrome, was kind of leading disease in complement drug applications. So, and they usually proposed a lifelong therapy. And we treat our patients for short time. So the differences are that we think that patients with HUS have a complement gene mutations that predispose them to vulnerability under any stress to develop this disease. In our transplant population, we show that patients have usually complement gene polymorphisms, and under regular life situations, usually they're not very significant, but if you subject patients to a very high stress, then those TMA can occur. And usually when stress is over, TMA resolves, we don't have a chance to develop that again, and we're able to treat those patients for a short time. And that's what I think would be also applicable to other therapies, that you have an expected high surge of cytokines or stressors like gene therapies probably. So we wanted to see, can we improve outcomes in our patients? We knew that high-risk patients have really poor outcomes. So we looked at all TMAs, we screened them prospectively in our institution. So low-risk TMA was those who had just hematologic TMA without proteinuria, without complement activation, and got no targeted therapy. And the high risk had both features, activated complement, proteinuria, and usually multi-organ dysfunction. And moderate was those in the middle. And we used urine protein creatinine ratio of 2 milligrams per milligram as a high-risk feature because that is a level of nephrotic proteinuria, which is very high. We also discovered through many studies, prospective and retrospective, that complement activation, namely terminal complement activation measured as elevated C5b9, is a high-risk feature of TMA, as I mentioned a couple of times. And we showed that using blockers, complement blockers, namely in pediatrics, we use C5 blocker eculizumab, we have most experience, and adults use MASP2 inhibitors, which is the lectin pathway inhibitor. We can improve outcomes in those diseases. We also showed that the higher C5b9 activation at the start of diagnosis, the more challenging to treat the disease, and it takes more medications to get the disease under control. So procrastination usually in those cases is not in favor of outcomes. We performed a study on those patients also. We looked at the patients who did not get complement blocking drugs, but they had moderate risk features. And we really determined that we can really, if we screen for TMA, we can really identify those patients in advance. We again supported our prior observations that elevated C5b9 is associated with threefold higher risk of mortality. We also identified that each patient has a baseline, what the complement activation is. So it's not really a laboratory value that matters, but where you escalate from your baseline. So we showed that our patients would double C5b9 number from the pre-transplant baseline, and if they sustain it for longer than a couple of weeks, they usually have a risk of high-risk TMA, this multi-organ injury. And we also showed that the long-term outcomes, like renal outcomes, are better even for those survivors, of course, who were high-risk TMAs but treated as compared to those who had like a moderate TMA and were not treated. So definitely we can make a difference here for long-term outcomes. The most experience we have with drug eculizumab, which is not approved indication for transplant-associated TMA, is approved for AHUS, PNH, now myasthenia gravis, and neuromyelitis optica spectrum disorders. And it's a humanized chimeric anti-C5 monoclonal antibody, but we adopted its use in transplant-associated TMA with some adjustments. Here is a busy figure, but I just wanted to show you. If you look first at the red line, that's where our outcomes of our patients were before we ever treated them for high-risk disease. And I'm going to mention again, only high-risk disease patients were offered complement blockers in our field. And the moderate and low risk were not treated. So low risk, as you see, without interventions, they're doing well. Moderate, they have so-so outcomes. And the high-risk disease now with therapies, we moved them up to about 66% survival from 16.7% survival. And overall survival post-transplant was 9% in those untreated patients before. So it's a good improvement, but we're not there yet because complement, again, is not the only one pathway involved in TMA, and we still need to learn how to use in less severe disease. So we're doing steps right now to improve those outcomes further. Here's a quite busy schemas, but I'm just going to deliver main message. First, if you look at the left figure, so it just demonstrates that C5b9 is a marker that is associated how fast your drug like eculizumab will be cleared out of the system. So mAbs are usually target-based medicines, and they depend on how many targets are there. So more targets, faster drug clearance. So we use C5b9 marker for TMA diagnosis, as I mentioned. We use this as a risk stratification or prognostic feature, and we also use to assess therapy outcomes because as it normalizes, it shows that C5 generation from affected tissues is subsiding. The other very useful marker is CH50, which is a figure on the right. It's a total complement activity. So first of all, when we didn't have eculizumab drug levels available, we used it as a correlative measure for complement suppression in blood. So if you give a drug and CH50 is suppressed below 10% of normal value, that means your complement is blocked in the blood. Also, it's a very good feature and a very good lab to follow. If you stop the therapy, you want to do antimicrobial prophylaxis until CH50 normalizes after therapy stopping, because that indicates that complement activity resolved and reestablished. So those are very good markers to use. Here's a very quick illustration, again, on the busy figures, that eculizumab clearance also depends and different if patients have intestinal bleeding or not. We in our field have patients with intestinal TMA who have very significant clinical bleeding for days and days. So patients without bleeding, usually as disease control happens, they slow down drug clearance and then they can stop therapy. And patients with bleeding need much longer, much more personalized therapy. So we're developing different algorithms and calculators, how to calculate the clearance of the drug based on patient's clinical condition. And just an example of this calculator showing clearance curves on the right side. Again, I just wanted to mention the concept per se that eculizumab and other complement blockers could be mAbs, and they depend on the targets, how they work. So if you have a target, they will be consumed and used, and if you don't have a target anymore, they would not be used as a drug because there's nothing to block. So that's why when we have active TMA, it's like this forest burning. Yeah, we need lots of drug and intensified regimens, and we use intensified regimens to compare to HUS because our transplant TMAs are much more active. But you know, when process is over, there are no targets anymore. We stop the therapy because there's nothing to block anymore. So it's good that we have those tools to tell. We have all tools to tell. Now, I wanted to mention about complement and T cells, because we use so many therapies where we have immunomodulation in transplant and other therapies like gene therapies. So can we use complement blockers safely? We showed that we can use it safely because T cells usually have what they call it complosome, internal T cell complement system that works, and a C5 blocker like eculizumab does not block it. So their T cells are functioning. So it was very important to know. And T cells also work with an interferon system that talks to complement too. So we're learning those things, how to use those comprehensive complex therapies together so they don't cancel each other. We also show that we can use other T cell therapies like antiviral T cell. It's a busy slide here too, but the point is here that we used a complement blockade, this antivirus specific T cell therapy, because those patients often have TMAs. And we demonstrated that under complete complement blockade, those T cells expand and they do the work that they're supposed to do, as it would be in patients who are not under complement blockade. So those are very important observations because we want to make sure that we are not using therapies that cancel each other. So what could be a suggestions for gene therapy TMAs for management? I think one of the suggestions that I have, and I strongly feel about it, it should be a TMA screening. It's very easy to do. We have those labs, majority of them at least. It's a CBC that's differential, looking for platelets and hemoglobin and schistocytes and LDH, haptoglobin. A random protein creatinine ratio is a very, very good marker of a kidney injury in a TMA. Hypertension is a very good marker. We've proved it many times. And also terminal complement activation. This lab is limited to some major institutions, but it could be done on pretty fast turnaround. And now, if one has impending TMA, I think in gene therapies, if someone has new thrombocytopenia, complement activation, that's a big signal. And then if you have another microangiopathy marker or associated organ injury, those are patients should be kind of assessed more for TMA and considered for therapies. What can we do better now? We can, together improve awareness. We can work on early diagnosis, this prospective screening and recognizing organ injury. It's very important to educate your multidisciplinary collaborators like, kidney doctor, nephrologists, cardiologists, because you need an ICU team to be involved and know about those patients. And learn, can we apply early interventions in certain selected patients who would benefit? And definitely long-term survivors, because effect on the organ stays for a long time. So here's just to conclude that, complement is not the only pathway. We know that other pathways are involved in the TMAs right now. And as we gain more medications, like we adding our knowledge and hopefully we'll have a comprehensive multi-drug therapies for those patients in the future. We know that interferon pathway is very important. And we have interferon gamma blockers right now. We know that neutrophil extracellular traps are very important, especially for lung injury. Coagulation system is very important. Certain viruses like BK viruses and other viruses can trigger. So we're learning and we're adding to this knowledge. So it's not going to be the only pathway. We learned most about complement because therapeutics were available. So we took that opportunity to learn and to apply and make a difference. And there's also interactive way to learn about TMA. We created this very cute cartoon for our young patients to explain complex problem like TMA. So I invite you to watch it. And with that, I would like to say thank you again for inviting me to present. And I would be happy to answer any questions. Thank you very much.
This was a very actually informative session, and I am sure we're going to have many questions. I have few here. So I'm going to start with few of those, and then if the time permits, I will add a few more. First, the question is from one of the attendees. It says, what about the rest of complement factors? They can mediate inflammation without the terminal complement activation and can contribute to the TMA or any other complication associated with gene therapies.
Would you like me to answer that question, I assume?
Yeah. Mm-hmm.
Thank you very much. So yes, we are learning about full cascade in different parts of the cascade. So idea would be in the future to target only what's needed. If we can identify specific pathway of the complement pathway target that could affect particular problem and solve it. There are some disorders that we know already that blocking at C3 or lectin pathway C1q, could be beneficial. But we started learning kind of from a bottom because that's where endothelial injury is at C5b9 level. That's where physical attack happens with MAC complex. So we blocked at this, and some parts of the complement still remain unblocked higher, which probably gives reasonable exposure and fight for infections, that we don't get like a fungal infections usually with C5 blockade. So, but in the future, I think we're going to learn probably for particular disorders or particular conditions that maybe we can be more selective, and we're striving to do that. But so far, I think best what we have in this, it's a terminal blockade so far. Or like lectin, like I said, in adults, people have lectin exposure, but we have best handle on C5 blockers.
Okay, so I'm going to ask you actually a practical question. And so we had few patients who had laboratory evidence of TMA of varying degrees. Unfortunately, the complement levels take a long time to come, and whenever you need to make a decision. So what is the best indicator of microangiopathy among all the parameters that you discussed?
In our world, as I was presenting, we have a different, like any complication, you have a different level of TMAs. So in the transplant population, stem cell transplant population, we showed it quite well that if one has only hematologic TMA without complement activation, usually these patients resolve TMA without any interventions. Now, so in our hands, complement activation is a very good feature to tell who's a very high risk and will get in trouble with organ injury. Proteinuria, again, it could be just a lung TMA or other, organ TMA. Not always kidney should be involved. Complement activation is one of the very significant features for risk. I understand that in your patient population, things evolve so fast and you have a brief period of time. So technically, it's very likely to be a complement activated disorder. So if you see features already like significant thrombocytopenia, LDH, or if patient is getting really sick, it's probably you almost can assume that complement be activated. I would send a lab, and probably if patient is really ill and you consider therapy, you can give a dose of a complement blocker, assuming that all conditions align and physicians decide on that. Everything is presented on assumption that you need it. And then you can get your labs back in that time. Those labs are getting more available and hopefully will be more available in time. But so far, complement activation is the best marker. You don't need even to align all TMA markers. If you have, let's say, a significant thrombocytopenia, let's say some LDH or some impending kidney injury and complement activation, you definitely should think that this patient at high risk for organ injury. So we hopefully will evolve some panels, but we're working on that to determine. In transplant population, hematologic features are not as important probably as complement activation and organ injury.
So I'm going to actually continue with the question. So actually in those patients, we proved that there was complement activation, but obviously the complement levels came a week later. I'm going to talk to you about a specific case that actually I think we had discussed. So basically there was progressive proteinuria in the patient with evidence of increased LDH, reticulocytosis, and relative thrombocytopenia. I mean, that was never in a dangerous manner, but we had increasing protein levels after the nephrotic levels. So in such cases, so we know that the protein is increasing every day, so there is some likelihood that there is kidney capillary involvement. So when is the time to consider, because you're going to do yay and nay, is that right, for the eculizumab therapy, then probably to stop the cascade of events? So when do you need to start considering, and what is the time frame?
$1 million question.
Yeah.
But I would say if you see only lab values that are not very significant changing, like some thrombocytopenia should be measured probably in a percent what you're dropping your delta. If you are going from platelet count of over 400,000, like to go to 150 abnormal, it's a pretty big drop. So we usually kind of offer to think if one drops more than 25% from what the baseline is, it's a significant drop. Same this hemoglobin, if you drop by like a gram of hemoglobin, since your patients hopefully don't have other underlying conditions at that point that would affect, let's say, platelet count or hemoglobin transplant, everything is mixed. And, but in my world, if I would be seeing impending organ injury of any kind, I personally would be worried knowing what I know. Again, these strategies have to be agreed between the groups and approved. It's a bit easier for me to say because we deal with very acute lethal disorder in bone marrow transplant population. And when we already see impending organ injury or evolving organ injury, you know those things will not really abort itself unless you intervene. If one would take a complement blocking agent only as an agent, taking away availability and cost and all those other issues, it's a reasonably low risk drug if you prophylax for infections, of course, and make sure that you take steps not to get meningococcal infection. But usually if you block it, complement for whatever time needed, and then later, blockade is resolved, you do not have a permanent damage to innate immune system. So it's not, it might not be a best comparison, but when people use steroids in medical field, yes, it's also immunosuppressant. It also affects lots of things. But if you use for brief time where it's needed and you don't use it any longer, then you are not really experiencing lots of side effects and you alter or control immune system just for brief time. But I would say as a physician, I would be very worried if you are seeing any clinical condition going towards organ injury. I would be worried, especially those very classic organ injuries. That's where we're trying to define them, how they look, how to recognize TMA-associated organ injury, because other complications can occur. Yes, if someone is needing oxygen and oxygen requirements are increasing and lungs look semi-clear, not like a fluid overload, it's likely it's a vascular injury. So you have to be a good clinician to differentiate those on the spot. The clinical tools and clinical assessments are very, very helpful if you understand primary pathogenesis of TMA and how organ injury should present. So just training yourself to recognize those.
Thank you. So there is one question about whether there are any less costly alternatives. I will actually a little bit tweak that question. Obviously, when there is organ injury and whether we can prevent it, maybe cost is not the most important thing that we need to think about. But are there any mitigation strategies for the milder cases that can potentially prevent the end organ damage?
Short answer for complement blockade and mediation, probably nothing directly affects as a complement blocker. If you have a pathway activated and you need to control it, the best way is control it with a targeted therapy. Now we're working on understanding other pathways because complement does not work in isolation. This works with interferon system and neutrophil extracellular traps. Different systems, nothing so far that you could physically giving one medicine that is not complement blocker to block the complement, that we could see it. We paid attention to some steroids because steroids work through interferon systems, and that would be a mediator. Unless you do it very, very early, probably maybe could affect a little bit, but not as impressive as, of course, complement blockade. So I can't speak to steroids that they would be a substitute. We looked at prophylactic measures, even like an N-acetylcysteine, like NAC, to prevent TMAs. Like some vitamins even modified, like vitamin D modifies, vitamin A, vitamin C modified endothelial health. But we're talking if you are evolving TMA probably as a more slow process, you could probably prevent with these drugs. If you have a very severe surge, like you see in the gene therapies, very acute and very severe, it's probably not very likely that at this moment is what we know that something else would control complement as fast and as proper as a complement blocking agent. Not saying that other immune modulators could not, but if you really need to be very fast and very precise, that's the only way so far to go. But hopefully we'll get that answer in the future if we can get the combination of medications. Or I think the preventing that from happening would be another really important area that we should be working. Maybe we can modulate something up front, how inflamed these patients come into the procedures, what immunosuppressants you use. All those modulations could affect like your vectors. All those modulations could affect what TMA presentation you will have. And if you have just a little bit, it's not going to hurt you. But if you have a very severe, it will hurt organs. So I think it's work in process. We'll get those answers.
Okay, thank you. I think the time is up. I just have one more question. So one of the attendees is asking, how can we tell early on if the case is going to be milder? So we just, procrastinate as opposed to we start getting the ectozumab ready. So is there anything to differentiate? Obviously, the complement levels is one, but any other clinical indicators?
Even if you screen it with all hematologic markers and everything, like we're discussing at the lecture, if you know your patient's baseline, how you're coming into the procedure, and just the change from your baseline tells you really a lot. And if you look at the one time point for TMAs, if anybody gave you one time point of labs, it would be hard to say what happened. But if you have a pre-procedure baseline, and then you see how fast thrombocytopenia is happening, how fast the blood pressures are changing or proteinuria, you would be able to identify by that delta of the labs how it's changing. It will give you a very clear signal. As we screen patients in transplant, we see those evolving very quickly, and we can tell who's going to be in trouble. I think prospective screening is a really strong emphasis on those discussions where to start before even going to significant drugs.
Okay, thank you. This was very helpful. Actually, for me, I am sure it was very helpful for the other attendees and who's going to be listening to this session later on. Obviously, these are burning questions, and unfortunately, gene therapy is something is very novel, and we still actually continue as we go learning about the potential issues. So I thank everyone who's attending, and I'm going to say that stay tuned for the last session of this year in December, that we're going to discuss the immune system and the immune system, how it impacts LSDs and how LSDs impact the immune system. Thank you very much for attending.
Thank you very much.